Hello, my name is Dan Barnett, and I'm an associate professor in the Department of Environmental Health and Engineering at the Johns Hopkins Bloomberg School of Public Health. In this presentation, I'll be discussing bioweapons threats and their health effects. It's critical to understand bioweapons because we are facing an ever-broadening array of population health threats, and biological threats are chief among them. Let's begin with a discussion of biological threats. There are certain acronyms in emergency and disaster preparedness, and one of them is CBRNE, or CBRNE, where C stands for chemical, B stands for biological, R stands for radiological, N stands for nuclear, and E stands for explosive. In this presentation, we'll be focusing on the B in CBRNE, which is biological. One of the things I'd like to highlight is a characteristic feature of biological agents, as depicted here on the slide, which is that historically, biological agents have been characterized by interest and use by non-state groups and individual actors. Now, that's not to say that these other categories have not been of interest to non-state groups and individual actors, but biological threats have a particular tendency to be appealing from an intentional attack standpoint to these kinds of groups and individuals. This is not to suggest that the other categories depicted on this slide are not of interest to non-state groups and individual actors, but biological agents do have a particular tendency to be of interest to such perpetrators. Of note, there's a long history of biological weapons use dating back centuries, and I'll briefly discuss that on this slide. So actually, the use of bioweapons dates back nearly 1,000 years. One of the first documented examples of the use of biological weapons dates back to 1346, in which the Tartars catapulted bodies of plague victims over the walls in what is modern-day Ukraine. Also, plague spread from ships to Europe and ushered in the Dark Ages. So this has significant socio-political and historical implications. With regard to smallpox in the Americas, in colonial times, the British forces had planned to use smallpox on blankets and introduce smallpox to Native American populations at Fort Pitt. And epidemics of smallpox tragically decimated populations of Native Americans as a result. In the Cold War, the United States and Russia both had offensive bioweapons programs, and BW stands for bioweapons, or biological weapons. The U.S. terminated its program in 1969 and signed the Biological Weapons Convention, which went into effect in 1975, but Russia continued its program covertly despite signing the treaty. There was a Japanese cult called Aum Shinrikyo. You may have heard of Aum Shinrikyo in the context of a sarin gas attack in the Tokyo subway system in the 1990s. But this same group had experimented with Ebola and anthrax and attempted an anthrax attack. So it was interested in not only chemical agents, in the case of its sarin use, but also biological agents. In the 1980s, specifically in 1984, the Rajneeshi cult in the United States contaminated salad bars intentionally in Oregon with salmonella. And last but not least, in the wake of the 9/11 attacks, there were a series of anthrax mailings with anthrax spores being sent through the U.S. mail, and these were referred to as the Amerithrax attacks. And that is, unfortunately, another tragic example of mechanisms of delivery for biological weapons. Let's talk a little bit more in depth about biological threats. So when we think about biological agents, we're talking about quite a broad array of potential ones, including viruses, bacteria, fungi, protozoa, toxins, biological toxins, and prions. What I want to emphasize here, though, is regardless of the type of biological agent, a bioterrorism attack is the deliberate release of such an agent to cause illness or death in people, animals, or plants. Very importantly, when we use the phrase terrorism in conjunction with any term, terrorism is fundamentally a mental health assault on populations, and as tragic and horrible as the physical impacts are, ultimately from the standpoint of one who intentionally releases such agents, the goal is to terrorize populations and cause psychological capitulation. Having said that, a bioweapon generally consists of a biological toxin or a live biological agent, along with the delivery system. And one of the things I want to highlight in terms of the delivery system is these can be very simple. Everything from a truck-mounted sprayer to a fire extinguisher to even an asthma inhaler can theoretically and realistically, unfortunately, be used as a delivery modality for a biological attack. In order to be effective, from the perpetrator's standpoint, an aerosolized biological agent has to be of the right size so that the biological particles stay suspended in the air and are inhaled into the lower lungs, where they can take root, cause infection, and enter the bloodstream from there. Importantly, recognition of a biological attack is critical for rapid public health response and optimizing outcomes in saving lives. So a bioweapons attack will likely be covert, and that is one of the inherent aspects of biological agents, as we will talk about later. One of the reasons for that is what's called the incubation period. So the incubation period is the time from when I, for example, get exposed to a biological agent and when I start showing symptoms from that exposure. As we'll see in this presentation, the incubation period of some of the chief biological agents of concern can vary from hours to weeks, and that's a critical aspect of bioterrorism preparedness. Because bioterrorism agents occur naturally, with the exception of smallpox, it can be difficult to recognize an epidemic as intentionally caused right away. And one of the key aspects of recognition of a biological terrorism event is good clinical assessment by alert clinicians. This includes taking a detailed travel history, which can be an important indicator. For example, if someone has not traveled to an endemic area of the particular agent and shows symptoms from that agent exposure, that should raise suspicions. If we see multiple cases of an unusual type of clinical presentation within a single geographic area, that could be another sign of concern. We may alternatively or additionally see more severe disease than expected, primarily respiratory presentations, for example, or unusual strains or unusual resistance profiles to antibiotics. These are all tip-offs for the alert clinician, and alert clinicians are truly on the front lines of recognition for a biological event. Detection is also likely to occur via environmental detection. For example, through a program called BioWatch, which involves detection of biological releases in the United States. But critically, again, it's the alert clinician who's on the front line of recognition. And awareness of what's occurred will, by general definition, develop slowly. And we'll talk about the reasons for this, but the where, the who, and the what in terms of where the outbreak is located, the extent of it, who is affected, and what has occurred is something that is a slowly evolving situational awareness aspect of bioweapons in comparison to other kinds of threats that we talked about earlier in this presentation, such as chemical and radiological and nuclear and explosive. So, as I mentioned, the incubation period is the time from when one gets exposed to when one starts showing symptoms. And by definition, as a result of that, we are always playing a game of catch-up in terms of recognizing that a biological attack has occurred, depending on the incubation period of the agent in question. The incubation period can also vary not only by the biological agent, but also by the underlying health status of the victim. Now, on this slide, I really want to highlight different categories that U.S. Centers for Disease Control and Prevention, or CDC, applies toward distinguishing different types of biological agents. We're going to focus today on the Category A agents, which the CDC, as we'll talk about, deems to be the highest priority. And there are several reasons for that, and that's depicted here, and we'll go into this now. So the CDC calls Category A biological agents high priority because these are organisms that pose a risk to national security for a variety of reasons. First, they can be easily disseminated or transmitted from person to person, although, as we'll see, not every Category A agent is person-to-person transmissible. Category A agents typically can cause high mortality, and they have the potential for major public health impact and societal disruption. The next category, which we'll highlight here, but we'll go into less detail in this presentation, is the Category B agents. This is deemed the second highest priority category of bioweapons to CDC because these organisms are moderately easy to disseminate, as opposed to Category A agents, which are quite easy potentially to disseminate. And Category B agents can cause moderate morbidity, in contrast to Category A agents, which, as we just mentioned, can cause major morbidity. And Category B agents cause relatively lower mortality than Category A agents. So I'm intentionally distinguishing between these two categories that CDC utilizes in its definitions of biological agents. The third category that I want to mention now is what CDC refers to as Category C biological agents. And CDC deems these agents as the third highest priority. These are typically emerging pathogens that could be engineered for mass dissemination in the future. And last but not least, we have new genetic technology, which has double-edged sword implications. A lot of the genetic technology that we have that can be so useful for gene therapy can also, on the flip side, be malevolently used to change the essential genetic components of biological agents so they exhibit new properties that we haven't seen before. And that's why biopreparedness is such a challenge more than ever before.